objections? Yes. Okay, I've got Representative Bueller. Go ahead.
Thank you, Madam Chair. I'd like to introduce 24 RS 2895, and that's on behalf of the Kansas Optometric Association. And I don't have the hard copy with me yet, but this bill would update certain procedures of the optometry law relating to scope of practice.
All right, without objection, seeing none, Chair recognizes Representative Clifford.
Thank you, Madam Chair. I'd like to introduce 24 RS 2584 on behalf of the American Chronic Pain Association.
All right, without objection, seeing none, accepted. Representative, did you have one, Representative Turner? Representative Reese.
Thank you, Madam Chair. I have two. The first one is 24 RS 2700, and this is enacting the Dietitian Licensure Compact to provide interstate practice privileges for a dietitian, and this is on behalf of the Board of Dietitians. And then I have 24 RS. Sorry.
Okay, just a moment, though. Is there objection?
Yeah,
Seeing none, accepted. Proceed, Representative Reese.
Okay. Big difference. 24 RS 2887, and this is updating requirements for receiving and renewing a license under the Dietitians Licensing Act. I don't have copies of these yet.
Well, and that's fine, because we're actually running into kind of things crossing in the night.
Right.
But we want to get these introduced. So without objection, seeing none. Is there anyone else with bill introductions? All right, seeing none, I have a couple here. I have 24 RS 2885, continuing care, retirement communities for insurance department, from the insurance department to KDADs. Without exception, seeing none, accepted. Next is 24 RS 2899, pregnancy compassion program and public awareness campaign. Yep, that's what it is. So without exception, seeing none, adopted. 24 RS 2900, no surgery for childhood gender affirming care. Without exception, seeing none, accepted. No more RS numbers or yet. Okay, here's what our plan is, committee, just to give you a heads up. If you've got a bill, or you know someone that's got a bill that's asked you to look at a bill, please get with them. Our goal is to have all of our introductions done by tomorrow. I know the deadline is Monday, but we're trying to give our reviser a day where she can catch up with some things. You do not have to have the bill, the hard copy, in your hands. We just need the RS number. Any questions? So listen for tomorrow. Because if I get calls today that says, hey, I've got a bill introduction, we will call a committee meeting only for bill introductions. Good?
Understand.
All right. And I will, listen for me at the well, because that's where you'll hear the announcement. Because there's no way for Dave to turn that around within our system on the agendas. So, okay? All right. Now, committee, we're going to open up the hearing on House Bill 259, authorizing the Board of Emergency Medical Services to distribute non-prescriptive over-the-counter medications. First, we'll hear from Reviser Jenna Moyer to give us a brief explanation of the bill.
Thank you, Madam Chair. Jenna Moyer, Revisor Statutes Office. This is House Bill 2579, and it amends KSA 65, 61, 44, which are the authorized activities for emergency medical responders. And this statute gives you the list of things that an emergency medical responder can do, and it adds to those, the distribution of non-prescription, over-the-counter medications that are approved by the EMS medical service director, except, and then this is the language on page 2 in lines 7 through 14, it does not allow them to distribute Sudafed. Anything that is and this is language from the Board of Pharmacy, anything that is a methamphetamine precursor would not be allowed to be distributed. So this would be just your common over-the-counter medications. I'll be happy to answer any questions.
Committee, are there questions for the reviser? All right, seeing none, thank you very much, Jen. I appreciate it. The first proponent conferee that we have is Jason White, Mid-America Regional Council Emergency Rescue. Welcome to committee.
Thank you very much,
You need to hit the button there.
It's green.
Oh, is it? Okay.
Jason White. So I'm here for Mid-America Regional Council. It's Council of Local Governments around Kansas City, Missouri, both Missouri and Kansas side, 35 ambulance services, 20 hospitals. We meet and do a bunch of policy work. This is a very simple bill. This is simply clarifying a situation in our current legislative language that prohibits paramedics from handing out Tylenol. So if you got a headache today, I'm happy to give you some Tylenol. But the folks in uniforms behind me are prohibited by law from helping out. It's an oops. Quite honestly, it's been there for quite some time. It causes complications when they're staffing football games and county fairs and warming centers and all kinds of places where these over-the-counter medications are fine for anybody in the state to distribute except for people with a EMS license in their pocket. I will tell you, I got into this because in the metropolitan area, we have some services that are wanting to do a Narcan leave behind. And Narcan's an over-the-counter medication. We discovered not allowed because it's an over-the-counter. 39 other states are doing that. It's not a red or blue issue anymore. It's just across the board. As we discussed this issue with our fellow service directors around the state, they said we need to deal with the entirety of the problem because they'd been putting up with the fact that they're helping out at these different events and having people ask for these things. They're putting them in their first aid kit for their self-care. Firefighters are asking for help with a headache on the grounds of a home fire, and they can't provide a Tylenol to them. So the language you've got covers all of the over-the-counter medications. This fits. This is common across the nation. So I've researched, again, I mentioned looking at just the Narcan leave behind, 39 other states, red and blue across the board. When I went looking to see are there any states that prohibit EMS from supporting the distribution of over-the-counter in these kind of first aid encounters, couldn't find any. So I went at it another direction, and I did find New Mexico. So the best of my knowledge, we're in a really rarefied air in stepping into this. And how did New Mexico deal with it? Exactly as we've brought forward to you today. Just language that turns it over to the agency. And that's an organization you can trust. Most of our services are run by cities or counties. And so they're going to look at it from a budgetary and operational perspective. They've got a manager, and they've all got a physician medical director. So this isn't going to open up brand new pharmacies running around the state by any stretch. It's simply going to codify what we're trying and wanting, and in many cases already doing, with a wink and a nod to the reality that the law is saying they really aren't supposed to do that. So short comments. This is very simple, very straightforward. We attempted to deal with it through the interpretation of the current language, and I'll tell you, attorneys for Johnson County, Kansas and Wyandotte County, Kansas both separately looked at it and said, nope, our services can do this now. Board of EMS lawyers said no. We put them all together in a room. We still had the impasse. That happens. Best way to solve it is come to you and say, we're at an impasse. Let's clarify it for everybody involved. And I'm certainly open to any questions.
All right, I think what we'll do is get through our proponents, and then we'll take questions all at once. Thank you very much. Next, I have Paul Davis, Director, Johnson County Department of Emergency Services. Welcome to committee, sir.
Thank you, Madam Chair. Paul Davis, Johnson County MedAct, and I'll just simply reaffirm what Mr. White had mentioned and let you know that in Johnson County, we were specifically concerned with the leave behind Narcan, naloxone. In Johnson County, last year, there were 414 opiate-related patient interventions. That's 72% of all our overdoses in Johnson County. Now, about 7% of these result in cardiac arrest, based on our stats. So we've been on those calls where if we would have been able to leave behind naloxone or Narcan for that intranasal reception, it may have saved a life. So we're looking to this committee to help us move this forward and allow us to continue to provide good care for our citizens. Thank you.
Thank you very much. Next, I have Dr. Brian Beaver, EMS Medical Director. Welcome to committee.
Thank you, Madam Chair. I'm Brian Beaver. I'm a physician board certified in both emergency medicine and EMS and an active medical director in Kansas, currently with Bonner Springs and Edwardsville fire departments, but starting February 12th, I'll be transitioning to medical director for Johnson County, Kansas. And I want to express my strong support for this bill that will allow our EMS providers to be able to give out these over-the-counter medications. It fits perfectly within their skill set, and even more importantly, I think it aligns with needs of our communities. You know, our EMS providers are on the front lines making life and death decisions right now as we speak, and we task them with making life-saving decisions, performing life-saving procedures, giving out life-saving medications under incredibly pressured circumstances. So their training and experience makes them more than capable of being able to, managing and providing these medications like Tylenol and ibuprofen and all these things that are already over the counter because they've already been vetted for their safety. But I think this isn't also just about the medication. I think it's really also about us in EMS being able to meet the needs of our communities and provide accessible health care. I think we're very proud of the growing community paramedicine programs that are starting across our state. And these programs are able to bring health care to the doorsteps of our citizens who need it most. For example, many of our elderly citizens for whom just getting out to a primary care appointment could be quite a daunting task. But allowing these community paramedics and making sure that we are able to do the right thing and allow them to provide the over-the-counter medications will only enhance their ability to provide care and potentially reduce unnecessary emergency department visits and take some burden off of our healthcare system. So I would urge you all to support this bill. I think it's a step forward for healthcare in Kansas. It aligns with the skills of our EMS providers and also the needs of our communities. And I hope that we can empower them to have the tools that they need to perform the jobs that they do every day. So thank you so much for your time today.
All right, thank you very much. That was the last proponent. Is there someone? What?
Move one down.
Right, but.
No, he's.
Oh, he's oral? David Adams? Okay. David Adams, President, Kansas EMS Association. Sorry, I had confusion on what I was reading here. so.
That's fine. No problem. Thank you, Madam Chair. I'm David Adams. I'm the President of the Kansas EMS Association. We represent 117 EMS systems across the state of Kansas. I agree with everything that everybody has said. The only other thing I'd like to add to that is we are asking for this to be in statute, because there's been a lot of confusion over the 32 years of my career about what we can and cannot do. So for our system, I represent Riley County EMS Manhattan. So for 30 years at home football games, people come in and they ask for Tylenol, whether they're hot, whether they've had too much to drink, whether it's too loud. Same thing with basketball games. We've always said, no, we can't give you that because we are not allowed to distribute. So that is why we're asking for this to be in statute, to make this clear, and so that it's clear for when this bill is passed. And in 20 years from now, we can distribute these as long as they're approved by our medical director. We've gone through the training. We've done everything that we're supposed to do, and we're happy with that. We'll put that on. We'll do the training. We'll make sure our staff are credentialed and know what they're doing. But that's why we're asking for this to be in bill, not being a guidance document, not to be something that's kind of open to interpretation, because what's interpreted right today may not be interpreted the same way in 5 years from now. Thank you very much.
All right, thank you. And so that concludes our proponents. There's someone else that had testimony that thought they were on the list. All right. Committee, questions for the proponents? Representative Clifford.
Thank you, Madam Chair. I'd like to address a question to Dr. Beaver. I just wondered what your thoughts are. We in Western Kansas have a lot of long transports, and do you think that 2 qualified people would have to be in an ambulance in order to give Tylenol to someone who's being transported?
How would you define qualified people? I want to make sure I understand the question.
Yes, we're currently required to have 2 EMTs or paramedics in an ambulance to transport someone. Do you think we would need both of them to give these over-the-counter medicines?
I think specifically, if you're asking for an over-the-counter medication, I think that one could. However, if other medications would need to be administered, I think that it's important, particularly things like a pain medication, a narcotic, something like that. I think that in that case, it would be important that there would be 2 there to perform an appropriate medication cross-check that's routine in hospitals and EMS services.
Thank you. Thank you, Madam Chair.
Committee, are there any further questions? Representative Bryce.
Thank you, Madam Chair. Dr. Beaver, if you don't mind. Thank you.
Yeah, just stay up there and then we'll.
I'll hang out a minute.
Thank you for your testimony. I just had one quick question. It's more of a logistics thing, but when an over-the-counter medication is given by emergency personnel, what type of documentation is there? Do you have the patient's name, what was given, when it was given, et cetera, in case, God forbid, there's some kind of a complication later, you have documentation? I was just wondering about the documentation. Thank you.
Correct. Yes, sir. It would be only appropriate that any time giving a medication, whether that's, leaving a bottle of children's Tylenol on scene with a parent or naloxone or that kind of thing, it would need to be documented clearly in the electronic health record exactly what was given, what was left, who it was left for, et cetera. Yes, sir.
Very good. Thank you.
Okay, are there any further questions for the doctor before we have him get down? Representative Epley.
Thank you very much, Madam Chair. Dr. Beaver, thanks for being here. And just kind of segue off that, on medications that might require some special training, for example, Narcan, would that be up to the medical director or to the EMS director to decide what type of training? I mean, would it be individualized to each EMS service, or how would that work?
Yes, sir. It would be up to the medical director to determine what medications would be allowed to be administered within their system, as it is for our other medications right now. And then the medical director is also, in Kansas, responsible for ensuring that they have the appropriate training, knowledge, et cetera, to be able to administer and deliver those medications.
Okay. Thank you very much. Thank you, Madam Chair.
Representative Reese.
Thank you so much for your presentation. I was also wondering about the, not just the training, but more about the Leave Behind program. Can you say just a little bit more what that means?
Yes, ma'am. So Leave Behind programs can look various ways. So to keep things brief, it would be often at the scene where an overdose has occurred. We know that statistically speaking, there is a high chance that another overdose can occur on that same scene. And in many locations, what unfortunately happens is the next time that EMS is called, as Chief Davis mentioned, we often get there and the patient is beyond our ability to save. Whereas if we could have left naloxone on scene, it could have saved lives. I came from a prior EMS system where in another state where we were doing that before I returned home to Kansas. And we had a number of success stories, thankfully, by being able to leave that naloxone on scene so that the next time around someone didn't end up in cardiac arrest.
And this bill will clearly allow you to do that.
According to the listing, as long as naloxone remains over the counter.
Thank you.
Committee, are there further questions? All right, seeing none. Are there further questions for anyone else? All right, it sounds like we've got that done now. So, committee, you do have written testimony from 4 individuals. You have Rochelle Colombo, Executive Director of Kansas Medical Society, Randy Bowman, Executive Director, Kansas Association of Local Health Departments, Dave Johnston, Chairman, Region 3 EMS Council, and I'm going to totally butcher this name. Is it Ruah Hazabala Mohammed, Chairman of the Board of Directors, Kansas Public Health Association. Now we'll move on to opponents, and we have Joseph House, Executive Director, Kansas Board of EMS. Welcome to committee.
Thank you, Madam Chair. My name is Joe House. I am the Executive Director of the Emergency Medical Services Board, and we do stand in opposition to House Bill 2579. And that is actually because we believe the language is unnecessary. So I know that previous conferee mentioned that there was a prohibition on this. We see no such prohibition within state law. We know the practice is occurring across the state, and we're okay with it. So the specific question asked of our attorney was whether distribution of an over-the-counter medication was included as an authorized activity. The answer to that question is no, it's not, because it's not. It's not listed in there at all. The question we were never asked was whether it needed to be. The board's answer to that is no, it doesn't need to be either. This should be allowed. So if you need a bill to say that needs to clearly be allowed, great. If you don't need the bill to legislate something that's already being done, I think that's probably an even better idea, because language does have that ability, once it's in there, to never necessarily come out, whether it's applicable or not at that point. So we do believe that the obstacles that this does ultimately place, because in order to unlock that list of authorized activities, there is training that has to be done and be able to be documented. There is competency that has to be validated in order for these providers to be able to do that. There is a medical protocol that has to exist in order for them to be able to do that. Those are all obstacles. There's no reason to have the obstacles. If they can do it today within the current language, then let them do it. So the guidance document that was referenced by another conferee, we note in here within our testimony, the board is discussing this possibility on Friday. That's our next scheduled meeting. That guidance document would clearly write it as being it is not unprofessional conduct for someone to distribute an over-the-counter medication. We can absolutely include the language that includes the ephedrine and pseudoephedrine or the methamphetamine precursors, because that's actually a really good catch, and we would happily encourage including that language within the guidance document side of things. So it is a very awkward situation to come up in front of you and tell you that, but we do believe that House Bill 2579 is unnecessary, and I'm happy to stand for questions at the appropriate time.
All right, committee, you're our only opponent, so you get to stay up there. We'll take questions. Committee questions? I'm going to jump ahead of you, Representative Eppley, if that's all right. So let me ask you a question. I happen to be kind of a blunt individual. So if we put this law into place, is there any reason that you would try to stop moving this forward?
No.
Huh?
No, we'll follow the law. Yeah.
Okay, and I guess I'm having trouble understanding, quote, the obstacles. Because these individuals can give out lots of different meds, correct?
Correct.
Today, prescription meds?
No, over the counter.
No, today.
Yes, Madam Chair. When those criteria are met, they're the very first criteria in subsection A of this same law. When they meet those 4 criteria, which are those 4 obstacles, they can administer medications. Administering is that introduction of it into the body. Distribution is the handing it out for later use.
Right. Okay, I guess I'm just having a hard time understanding why, you know, it's an issue and it's something that hasn't been done. Because I'm thinking the other day when I had a headache and I was like, anyone in here have Advil? I need the Advil. And I'm glad I didn't have to jump through a bunch of hoops. Representative Eppley.
Yeah, thank you, Madam Chair. And I want to make sure I'm clear about this, Joe. Thanks for being here. And it is an interesting picture here with all these people that are for it, and EMS board is, you're representing them against it. But I think when it comes to quality assurance if these folks are under a protocol through their medical director to get training, particularly as it relates to naloxone or some of these over-the-counter, now soon-to-be over-the-counter treatments. I don't view that as an obstacle. I view that as a quality measure, because I think when people administer those drugs out just, you know, in the community, that it's most of them don't have any training at all. So this will actually be an improvement and not an obstacle. But while your passion is well felt, I need you to comment on how, I mean, it's up to each EMS unit to take this on if they want to. And so I don't see why the Board of EMS has much care or observation that this is an obstacle. Thank you.
Sure. Madam Chair, Representative, 4,500 of our 10,000 EMS providers are affiliated with an ambulance service. So quick math there, 5,500 of them don't have an ambulance service to protect or to insure or such, but these are the authorized activities for those individuals as well. So if for some other reason those folks are activated, they have that ability, this is still applicable to them because they hold that certificate. That's why the law is written to be permissive in nature, to ensure that those criteria are met. Once you start stair-stepping up the levels, those for the paramedic level, that frankly they can just do anything that the emergency medical responder, EMT or advanced EMT can do as just part of their scope. And so that is our concern as to why throw the obstacles up, is because we do think it adds a layer that's unnecessary.
So what do those other 5,500 do?
It's a very good question. Some of them work in hospitals providing that care. Some work for fire departments that provide first response. Some of them are within an industrial setting, but they simply just don't work for an ambulance service.
Okay. All right, committee, further questions? Representative Reese.
I'm now very confused. So we're talking about this Leave Behind program. So right now, party going on in my house, there's a bunch of drugs being used, and somebody's overdosed. I call 911, EMS comes, they can administer, right? And I use the word right, administer?
You did, absolutely.
Okay, they can administer the Narcan, but they can see there's a party going on, and there's probably other people there that are likely to overdose. They cannot leave Narcan behind. Yes or no? I mean,
I see nothing that would prohibit that practice.
okay, then why have I been told that they could not do that? Why do these other folks in our audience are saying this law is needed, this change, this wording is needed so that they can do that?
Madam Representative, if I knew that answer, I would love to have it as well. We see nothing that would prohibit naloxone leave behind from occurring within the state. It has been occurring within the state for the last 3 years. We've done nothing about it.
There's some disconnect somewhere.
I wholeheartedly
what I'm hearing.
agree.
All right.
Thank
For any further questions, committee? Representative Blex.
Thank you, Madam Chair. I mean, it sounds simple, but yet it's not. I mean, if you've got lawyer's opinion that you hire, and we've just heard that 2 of them said it's okay and another one said no, and the one that said no obviously had more clout. So if this thing's so clear, why are we having this discussion today with all these issues, with the board being seemingly against it, a lot of shining badges behind you that disagree, that fund your salary or somebody's, at least some portion of. I don't understand this. I mean, we should almost, and I tend to agree, we shouldn't even be talking about it. It either clear cut or not. Can you, I mean, why can't the lawyers figure this out? I mean, if you went to the AG or something and asked their opinion there, I mean, you're coming to us and asked for a statute. What's going on?
Representative, I think if the question were clearly asked, I think the answer would be the same regardless, whether it's my council, whether it's the other councils. Is it in the authorized activities? No. Does it need to be? Absolutely not. It's allowed today. There's nothing in law that prohibits that practice. That was the answer from the attorneys on the other side, but that wasn't the question we were asked, or my counsel was asked when he replied no. He was asked, is it within the list? And it is not within the list. It just doesn't need to be.
In your opinion, is this a concern maybe with let's say, for lack of a better word, a union issue or insurance issue that might not cover this individual that has some concern? You know, I can't do this. I mean, somebody's not being very clear.
My opinion, and I would agree, and that was actually our reason for the guidance document. That's the tool that the legislature has given our board the ability to communicate out things that we don't necessarily want to write a regulation upon or we don't want to write a statute upon, is to say, here is how the board is going to generally interpret these things as they're going through. That guidance document stays in place until, yes, the board can repeal it at any point in time, but it is at that point in time at which it would stop. That has to be done within an open meeting, so there's going to be discussions that occur regarding that if we were ever to repeal it. I just can't anticipate that we would. 35-plus years of it being allowed. So I echo your frustration, but I also see there's opportunities for us to more clearly communicate.
Thank you, Madam Chair.
Representative Epley.
Thank you, Madam Chair. Again, I'm trying to distill this down to simply an interpretation problem. You know, the State Board of EMS obviously feels like they can do this already, but there's several component organizations in EMS that feel that it's not clear and that they can't do that. So what is the harm in clarifying that in statute once and for all so it's clear for everyone in this room?
Representative, I say there's no harm in it. The board just believes it's unnecessary.
Okay. Thank you, Mr. House.
Yep.
Thank you, Madam Chair.
All right, committee, any further questions? Representative Bueller, last question.
I'm not trying to belabor the point, but clearly you believe that the statute already permits this. So, and I think I heard you say something to the effect that you thought it would lock you down or prevent you from some future over-the-counter medication. Is that, in other words, by codifying this, you're locked into a set of over-the-counter medications, and if there was some other medication that we would have to go and then change the statute again to allow that? Is that what I heard you say earlier?
Madam Chair, Mr. Representative, no, that is not the case. It locks them down to requiring those 4 components in order to unlock this activity as an authorized activity. So they have to meet those 4 pieces. Once they meet those 4 pieces, then their authorized activities become unlocked.
Okay, but clearly you, believe that the statute permits both administering and the distribution piece that we're talking about.
The statute clearly covers the administration, and there is nothing within statute that would prohibit distribution
Okay.
within our Board of EMS statutes.
Okay. Thank you, Madam Chair.
All right, committee, seeing no further questions, that will close the hearing on House Bill 2579. Thank you very much for being here today. Committee, at this time, without objection, it is my intentions to work House Bill 2579. Is there objection? Seeing none, Representative Bueller?
Move that we work House Bill, Madam, 2579.
Is there a second?
Second.
Seconded by Representative Epley. Discussion and comments. Representative Orpeza.
Thank you, Madam Chair.
I heard you might have something.
Yeah, yes, thank you, Madam Chair. I would like to amend the bill and strike outdated language in lines
15?
Yes, 15, and the specific lines when authorized by a physician through 16. I would like to strike those, Madam Chair.
That's a motion?
Yes, a motion, please.
Is there a second? Seconded by Representative Reese. Discussion on the amendment. Seeing none, Representative Orpeza, you may close.
Thank you, Madam Chair, and that's all I have. Thank you.
Just say close.
Closed.
There you go. All right, all those in favor of the Orpeza amendment signify by saying aye.
Aye.
Oppose? The ayes appear to have it. The ayes do have it. Motion carries. Representative Clifford?
Thank you, Madam Chair. I have an amendment.
Okay. What do you have?
I would like to add either in line 18.1 or in a new line between 18 and 19 down below, the following language. In counties with a population less than 10,000, provide transport with one person that is certified as an emergency medical responder and a second person that either meets the same requirements or is a person certified in first aid or cardiopulmonary resuscitation.
Is there a second on the Clifford amendment? Seeing none, we're not on your amendment. There's no second, for lack of second. Committee, is there further questions on the amendment or the bill? And I think Representative Clifford, I understand where you're coming from, and I think a separate bill so that we could have a thorough discussion, because for personally myself, would not feel comfortable making that decision without hearing from all of our experts out there talk to us about what that ramification. On the other hand, I understand exactly where you're coming from in rural Kansas. That creates some difficulties for you. So if you were to get something like done really fast and, yeah, but you don't know that. Then perhaps there would be an RS and we could make it happen. Okay?
Yes, thank you, Madam Chair. We have Senate Bill 212, so I'll work with the advisor.
Okay.
Revisor. Thank you.
Great. Thank you very much. Committee, are there any further questions, comments? Representative Bueller, would you like to move your motion? You were going to move adoption of the bill as amended.
I would move adoption of Bill 2579 as amended.
And seconded by Representative Reese. All those in favor signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Now, committee, if you'll turn your attention to, and let me get my stuff put back where it belongs. Get too many pieces of paper out here and then I'm lost. We're going to open the hearing on a bill that we heard yesterday. So we'll open the hearing on House Bill 2578. Representative Bueller?
Madam Chair, I move that we work House Bill 2578.
Is there a second? Representative Bryce?
Second.
Okay. Seconded by Representative Bryce. We're now open for discussion on House Bill 2578. Comments, questions, or amendments, committee? Representative Vaughn.
Thank you, Madam Chair. Just as a point of discussion, I'm still trying to understand why this seems like a zero-sum game. In terms of, we hear so much about the need for behavioral health services and the success of the CCBHC model. And, I think, in my mind, if we're trying to increase access to services, allowing as many provider types as possible to achieve this standard of care and to use this model seems like a good option. So I'm just struggling a little bit to understand why we want to take the action to limit this right now to one provider type. And it really is a question that I'm trying to inform my vote because I can see both sides of the issue, and I want to do the right thing, but just wanted to open that point for discussion.
Okay. Well, and, I can have one of the, because we do have some of the conferees in here from yesterday that could also, but I think from my personal perspective, I know that we have a concern on our border states wanting to move their CCBHCs into our state. And I'm not sure that that's a path that we want to take down. And so I think that's why you're seeing this happening now. It's not to prohibit more individuals in order to be able to provide these services. I think a lot of individuals that we heard from yesterday as opponents are small enough that the idea that they could ever qualify for a CCBHC would be daunting for them to even make that path. And I think that maybe perhaps they were a little bit misled on some things yesterday. Keep in mind that if we do this today, and again, like I said, I'm looking at what's happening perhaps on our Missouri border, this can always be reversed down the road, and it can be removed. Does that help answer your question, or would you like to hear from one of the conferees perhaps in more detail?
Thank you, Madam Chair. Yeah, I'm open to that. I would be curious to know more about what's happening in Missouri specifically, because I think that's my other thought is that if all the provider types have to meet the CCBHC standards and have to meet the same accreditation standards in order to implement this model, then they would be held to the same standard regardless of the provider type. So why would we want to open the door, or why would we want to go down the path of limiting who would be available to offer these services? That's kind of...
Well, the other issue you have, and if you recall, I spoke yesterday when I pulled the fiscal note from when we did the original legislation for CCBHCs. The fiscal note at that time for all of our CMHCs to become CCBHCs was almost $75 million. It is not a cheap model to have. I have been in contact with KDADs, and I know that they are looking at potentially opening up some codes that are unique to the CMHCs for other providers. Why is that a positive? That gives them the ability to provide some services that they haven't been able to provide today. And for the smaller ones, that gives them a door into an area that, being as they couldn't become a CCBHC, that they'll actually be able to provide more services. Does that help?
Yes, thank you, Madam Chair. I think, I'm still yet to be convinced, so I will probably be a no today, but I'm open to continuing conversation about this issue. Thank you.
And I appreciate that. And I think that there's any one of the conferees that you want to visit with would be happy to sit down and have that discussion. And I appreciate you bringing your concerns to the committee. So thank you very much. All right, is there further discussion, comments? Representative Reese.
Thank you, Madam Chair. I've also been struggling with this bill and how I'm going to vote. But there's some things that have become very clear to me. And one is, for me, the overarching issue for me is the continuity of care for the clients that are receiving services through now the CCBHCs, and clients also that are receiving services through the FQs. And it's been known that staff have been going from one agency to the other because one agency might have raised their salaries and not the other. Then the other entity raises their salaries, and then a case manager goes to the other place. I don't fault them at all, especially case managers who are direct service providers and do really, really hard work and are dedicated to that service. I don't blame them at all for trying to have a living wage or, or trying to, just to have a higher salary. It's become worse because of having the CCBHC designation now. I know that in social services budget we've been able to authorize more funding for, like at Larned State Hospital, and then you've got the prison practically across the street. Staff have been going back and forth from there too. The people who suffer when that happens are the clients, are the people that are receiving those services. I've worked firsthand with adults with a severe mental illness it takes them years at times to become comfortable enough with a case manager and to trust them enough to be able to be open to services and be open to medications or be open to employment or whatever it might be. Just to have the rug taken out from under them because their case manager is now leaving them to go to another agency because a higher salary. It's devastating to them. And I've been seeing that. I've been getting, I have constituents who tell me that this is happening. I know social workers that this is happening to. For me, this bill is not a hard stop. For me, this bill is a pause. It is putting a pause to this back and forth situation, allowing the CCBHCs to have more time to do all of the things that they have to do in order to fulfill the certification. And so it could be a CARF certification. They may also have to go for whatever it is that they have to do, having agreements with FQs or any other healthcare providers. I believe they need time to do that, and we already have seen, the chair has told us, that it's cost $75 million so far to try to get as many CCBHCs that we have now. We don't know what it's going to cost the state 2-3 years down the road. I think we need that pause to know what that's going to cost the state. And the FQs can then learn from that and see what that's going to do as far as their services and as far as what it's going to cost to the state, so that then we can then look at the FQs having the same certification. So that is where I'm coming from. It's continuity of care. We need a pause. Thank you, Madam Chair.
What I might remind the committee is that because of that fiscal note is why the CMHCs were phased in. We didn't get to do them all at once, which would have been my preference. But I understood that, and I think it's worked out really well, so each one could learn from the next one. Representative Blex.
Thank you for that opportunity. And boy, I'm really torn on this one too. I've got both issues in my district and have seen good work there. And I understand the fiscal note and the pause, but my record has shown I really kind of dislike picking winners and losers, which is kind of what we're doing. But I know we need to start slow and grow in this because of the high fiscal note. And we really don't know the cost benefit of this changeover will do to, as far as numbers of how many people they're doing. We haven't really seen, we haven't had enough time for a lot of data to analyze, but we do know the cost is there. I will more than likely be a yes vote on this, but I'm struggling with it, and because of the fact we are seemingly cherry picking a winner and a loser, so that part of it I don't like. Thank you, Madam Chair.
Well, and I think, Representative, I don't see this as picking a winner, or a loser. And, we've got, in my area, we've got several FQHCs. Our CCBHC is actually county-owned. Johnson County is county-owned. And who's the other one, Kyle? Crawford County is county-owned. The others are all, nonprofits in the community. I think the idea that, KDAD has of opening up some of the codes that have been unique to the CMHCs is going to be a plus for these other providers. So that's the other reason I don't feel like there's a winner or loser. And I think you stated it very well, talking about, and Representative Reese, is the time that we need to see how this whole CCBHC plays out and get all of them, because they're not all totally 100% certified. So that would, give us a good path, because anything that we put into law can take and be reversed. And so, but I appreciate your comments. Representative Bueller, and then Representative Barth.
Yes, Madam Chair. I appreciate the back and forth and the different perspectives on this. For me, and maybe it's my newness to the issue, makes it a little clearer for me. And I don't see it picking as a winner or loser as so much as it is the difference of competencies. This is an accreditation process for the CCBHCs as opposed to the FQCs, which I think yesterday the conferee said that if you look at what their core competency is, it's 90% physical health and 10% mental health. So we're dealing with the accreditation process for the CCBHCs, and it's primarily 100% mental health. So that is the easier distinction for me, and maybe that's not the best way to do it. But when I look at the certification process for that, and then just kind of put the two entities aside, it's easier to say, let's focus on the CCBHCs and let's make some traction on it. So thank you, Madam Chair.
All right, Representative Barth.
Thank you. I was pretty much going to say very similar comments as Representative Bueller, so that's it. Thanks.
Committee, further comments, discussion? Seeing none, I believe that Representative Bueller was our motion, correct? Back to you, Representative Bueller.
Yes, Madam Chair. I move that we adopt House Bill 2578.
Our second?
Second.
Now, who did we have as our original second? Who I'm looking for? Representative Bryce, I'm sorry. All right. Committee, all those in favor signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Motion passes. Okay, committee, once again, I'll reiterate, if you've got any bills, please get with Jenna so she can assign them an RS number so that if we need to, we can read those in tomorrow. We are working diligently for a couple reasons. One, Dave has to staff the Bob Bethel Can Care Oversight Committee meeting on Friday, so he's needing tomorrow to get ready for that. He needs Monday in order to get us ready for Tuesday. So we're trying to avoid Monday to also give Jenna time to work on all of these bills, because the drop deadline on that is Friday, but we just need to have them introduced into here. So if you have any, let her know, let me know, and listen for me to announce a meeting. Right now, we are just on the call of the chair tomorrow. So we are adjourned.